Before a paramedic can administer a medication, initiate an IV, or even apply a bandage, they must clear a strict medico-legal threshold. Without consent, clinical intervention is battery. For conscious, capable patients, the standard operating state is expressed consent. This means the paramedic must actively seek permission, securing a definitive agreement from the patient, either verbally or via a written signature, before any care begins. But pre-hospital medicine frequently operates at the extremes of human physiology. When a patient is unconscious, actively seizing, or in cardiac arrest, the pathway shifts to implied consent. This invokes a specific legal assumption that a reasonable person facing a severe, life-threatening emergency would authorize life-saving interventions if they possessed the physical ability to speak. Consent operates as the mandatory legal gateway. It dictates exactly which clinical pathway a paramedic is permitted to travel. This flowchart from the Healthcare Provider's Guide outlines the required sequence for obtaining valid consent. A signature on a tablet holds no legal weight unless the patient has been properly informed about the proposed care plan. The provider must first explain the exact clinical nature and purpose of the proposed healthcare. The patient needs to know exactly what is going to be done to their body. Second, the paramedic must outline the expected physiological benefits. This explains why the intervention is necessary and what a reasonable person would expect to achieve. Third, there is a strict legal obligation to disclose any material risks or potential side effects. The patient must understand the medical dangers associated with the procedure. Fourth, the provider must present any viable alternative courses of action, including the likely medical consequences of refusing the treatment entirely. Finally, the patient must be given a clear opportunity to ask questions and receive understandable answers. By satisfying these criteria, the paramedic achieves true informed consent. This effectively shifts the legal liability for the health outcome from the clinician directly to the fully briefed patient. Evaluating a patient's ability to make these decisions requires measuring decision-making capacity. Capacity is not a static, global status tied to a specific medical diagnosis. It is a dynamic, decision-specific functional state. The assessment begins by identifying if there is an acute impairment or disturbance in the functioning of the mind or brain, such as hypoxia, a head injury, or intoxication. If an impairment exists, the clinician applies a 4-stage functional test. Stage 1 determines if the patient truly understands the specific clinical situation and the medical information provided. Stage 2 tests retention. The patient must be able to hold the provided medical information in their mind long enough to process a decision. Stage 3 evaluates logic. The paramedic observes if the patient can rationally weigh the risks and benefits as a cohesive part of their reasoning process. Stage 4 confirms communication. The patient must possess the ability to clearly convey their final choice by any means, whether verbal or nonverbal. Often, patients make choices that run contrary to medical advice. However, poor judgment or an unwise decision does not legally equate to a lack of capacity. A capacity assessment requires interrogating the process of a patient's reasoning. It does not allow a clinician to judge the outcome of their choice. Competent adults possess the absolute legal right to refuse medical treatment. They retain this right even if their refusal will lead directly to serious injury or death. To manage the immense liability inherent in these scenarios, paramedics deploy a mandatory structural tool known as the VRCA framework. The V stands for voluntary. The patient's decision must be completely free of coercion from EMS providers, family members, or law enforcement. I is for informed. A refusal is only legally valid if the risks and consequences of declining care have been thoroughly explained and understood. R means relevant. The refusal must apply directly to the specific medical complaint and the current situation on scene. C requires capacity. The clinician must confirm that the 4-part cognitive algorithm has been fully satisfied. Finally, A is for advice. Paramedics must provide targeted, specific worsening advice, detailing exactly when to call 911 again before discharging the patient. Applying the VRCA structure standardizes the interaction. It transforms a chaotic, high-stress refusal scenario into an objective, legally defensible protocol. The standard consent algorithm shifts when clinicians encounter specific demographics, governed by regional legislation like the BC Infants Act. Under this act, a minor can make independent medical decisions if they meet the criteria for a mature minor, demonstrating the intellectual ability to fully understand the proposed care plan and its risks. Conversely, when adults fail the capacity assessment, they lose the ability to advocate for themselves. Paramedics must then consult a prioritized legal hierarchy to find a substitute decision-maker. This hierarchy begins with a court-appointed personal guardian, moves to a designated representative, and finally to a temporary substitute decision-maker, or TSDM. The TSDM is legally bound to decide based on the adult's known wishes or their best interests. In some cases, the patient has already provided instructions through a valid advance directive. This document grants advance consent or refusal directly to a healthcare provider, bypassing the need for a substitute. When patients lose the ability to speak for themselves, paramedics cannot guess their preferences. They must rely entirely on these predefined legal hierarchies to ensure their interventions remain lawful. Operational friction often occurs at the intersection of medical autonomy and law enforcement authority, specifically when treating patients in police custody. A common misconception is that arrest strips a patient of their rights. In reality, patients in police custody retain their full medical autonomy and the absolute right to refuse clinical treatment. However, this autonomy has physical limits. While they control their medical care, individuals in custody generally lack the legal right to refuse physical ambulance conveyance. The specific operational protocol for these cases requires paramedics to approach the patient with the intent to convey, utilizing a law enforcement escort. Law enforcement dictates the physical location and transport of the individual, but the patient maintains absolute sovereignty over the medical interventions performed on their body. Non-transport and refusal scenarios constitute the highest liability risk for pre-hospital providers. This risk highlights the foundational medico-legal rule of pre-hospital care. If a clinical action or assessment is not documented, it never happened. During a refusal, the core purpose of the patient care report is to document the paramedic's clinical reasoning, not merely the final conclusion. The chart must contain specific, mandatory elements. Providers must record the patient's explicit mental status, their orientation, and the exact material risks that were disclosed on scene. Furthermore, the narrative must include exact patient quotes. These quotes serve as hard evidence, unequivocally demonstrating the patient's reasoning and their weighing of the risks. A vague chart leaves a clinician legally exposed. Rigorous, evidence-based documentation acts as an impenetrable legal shield, proving the paramedic respected the patient's autonomy while fully executing their duty of care.